Hello, everyone. I understand that everyone is in listen-only mode. I do believe that I will try to correct that so that everyone is able to share comments if need be. I want to ensure that everyone is able to see my screen. You can go into the chat section, and I just want to make sure everyone is able to see my screen. So please, someone respond back to me about the screen. Can everybody hear me now? Okay, Jane says yes, everybody says. Okay, so all you are supposed to see, okay, good. Thank you, everybody. Okay, so now what you are supposed to be able to see is the blueprint, okay? We're going to go through the actual exam blueprint, and I'm going to help you understand what each of those objectives means, and no PowerPoint. And I wanted to make sure everybody understood that there was no PowerPoint. I will periodically go look at the chat room so that I can make sure that I am questions and if there are any issues, okay? Okay, so we are on our screen and I am recording. So the very first thing I want to talk about is that you will see that this is your student blueprint, and this is for Exam 1 in Nursing 421. This level of Bloom's taxonomy going across the top in the colors is the difficulty level and the understanding level, we call it cognitive level, of the questions that are going to be in that objective area, okay? I will tell you the majority of what we are going to be working toward is that all of yours will be application and analysis. Currently, the only kind you've had have been knowledge and comprehension. So that means the questions that we're going to ask you in 421 are actually going to be more difficult. There's another step to it. We're actually going to have you think through some processes, which is why I want to go through this with you. Please know that there are 3 sections to this exam. The very first one, 10% of the exam, approximately 6 to 12 of the questions, will be about the IOM, the U.S. Healthcare Nursing Practice Now and Future, and the IOM reports. The next section is the cardiac section, and it's the biggest, and it will cover 55% of the exam, anywhere from 15 to 29 questions overall. The last one is the respiratory. Okay, I actually have several people who say they do see my screen, others who do not, so I want to make sure everybody's doing okay. Okay, actually it says I'm Miss Swint, but I'm actually Professor Land, and I'm the professor on main campus. You guys doing okay there? Okay, great. Thank you, Jennifer. Okay, Priscilla, good. Okay. Now, we have actually, again, respiratory is only going to cover 35%, and then that gives you 45 questions. We add 5 math questions. Some of the other levels we're doing 55 questions, and my understanding is that's because they are actually beta testing 5 questions. Our level is not at the beta testing point yet. So you will do 50 questions, 45 for the content, and 5 for med math. Now for the med math, I want to make sure that you understand these will be complex care medications and calculations. So like in the cardiac world, we talked about dobutamine. Well, you need to understand what is dobutamine, what does it do, what's the normal dosage, and can you do calculations? Because remember, in your exam for med math, we talked about having medications that you're titrating up and down based on parameters, but you need to be able to calculate not just milligrams a minute or milligrams an hour, but now we're talking about micrograms. We're talking about micrograms per kilogram per minute, micrograms per kilo per hour, and then you make sure that you understand what the question is asking. So if you do the calculation and then it says give the answer in milliliters per hour, and you put the micrograms per kilogram per hour, then you're going to get that question wrong. So just be careful and ensure that you know what the question is asking and you can answer that appropriately. So the first thing I want to go through is this blue section. You guys see the blue going all the way across. Okay, it stops at the application or applying level. That is where you will probably get the question level. So I'm going to ask you some questions, and I can ask you all the way up to the application level for those, okay? And if you will look at the first one, it says I can ask you 1 or 2 questions regarding this report. So that's how you read a blueprint. Now, where did we get these numbered objectives? These are the exact same objectives that are in your course syllabus for theory. And how we write the exams, we actually take the objectives, we plug them into this template, and then we go down and we actually share writing the exams. Like I would take Module 1, Objective 1 and 2, and another instructor would take 3 and 4. And we take turns in writing the questions, because it actually is very difficult in writing questions. And then what we do is we mix them all up, and then we select one, and we make that question 1, and no matter where it is on this blueprint, it might be right down here. I put the question number 1 would be right there, okay? So what you don't see is the question pieces. That's the instructor's view. Now, the very first objective is that you be able to summarize the major IOM, which is the Institute of Medicine, that you are able to summarize their quality reports regarding evidence from the 1999 report, okay, about the overall quality of care in the U.S. healthcare. So really what I want to say about Objective 1 is that you need to be familiar with the following IOM reports, and you can get the information from your Learning IOM book, okay? So for the following reports, you need to understand the report and the recommendations for each of them. So like the first one, 1999, is the report To Err is Human. This is where they were working on the fact that a lot of errors are actually not people generated but system-based generated, but that people were not reporting it. So make sure that you are familiar with that report. What the recommendations from that are ended up being, we needed to have national safety goals. And so National Patient Safety Goals, which you are now familiar with, was created at that time. And then they are updated every year. And then, of course, you need to understand errors and then respect human limits in the process design. So humans will make mistakes, but when we are creating our processes, we need to consider that. And we need to have the opportunity to do double checks, which is actually part of why nurses have 3 checks that they have to do for the medications when they get it out. And then you have to double check the patient, their name and their date of birth while they're saying it, and on their wristband. When you're giving medications, I actually pull up the medication sheet on the computer screen and compare that at the same time, because you are actually the patient's very last line of defense against any kind of error, not just a medication error. The other piece of the story is that nurses need to be able to expect or anticipate the unexpected. We need to have created learning environments, and we actually need to promote effective team functioning. So I, as a nurse, am in no way able to go down to the pharmacy, get the meds that I need for my patient, and then go back up and give them. There actually is a team involved in trying to get all of these out there and getting them out there safely. Okay. That's the first one. Want to go to the next one, which is Crossing the Quality Chasm, and that's the 2001 report. That's the report that the recommendation of healthcare should be safe, effective, patient-centered, timely, efficient, and equitable. Now, please remember, these are the core competencies of healthcare. Okay, so crossing the quality chasm, they came up with the core competencies of healthcare: safe, effective, patient-centered, timely, efficient, and equitable. The third one is called Priority Areas for National Action, Transforming Healthcare Quality, and that one is from 2003. So again, this is where they looked at some more information and more detail about those core competencies of healthcare. Yes, patient-centered, but they also said we should actually have interprofessional, interdisciplinary teams to promote that, that team functioning in the 1999 report. We also need to employ evidence-based practice, meaning our practice should be based on evidence showing effectiveness, and not just because that's the way we've always done it. We should always apply any kind of quality initiatives. So once we do something, we should evaluate what was the quality of what was provided, and how can we make things safer? How can we do a better job? And one of the ways that we can do that is by using informatics, and that's the last one. Informatics. You guys already see a huge component of that with the fact that all hospitals have now gone to electronic health records and electronic medical records. All physicians' offices have moved to the electronic health record because it was a mandate, a requirement. And you will see that technology, informatics and technology is actually becoming an even bigger component of healthcare, and it helps us facilitate patient-centered care and the fact that we can provide that a little more equitably, which is what the Affordable Care Act was supposed to help us do. Now, the last one, the fourth one that you need to be familiar with is the Future of Nursing, Leading Change, Advancing Health Report, and that's from 2010. The barriers that the recommendation that it has is that there are actually 8 of them. The first one is that there needs to be a removal of scope of practice barriers. So in your classes from your instructors, hopefully you talked about the fact that, you know, we have RNs who have high educations and they're educated and they're knowledgeable about some specific skills and duties, and there are some states that don't allow them. So Arizona allows the advanced practice nurse, the family practice nurses, to actually hang out their own shingle and practice nurse practitioner on their own license, as long as they have a physician that they can refer to. Now, we're one of the few that do that. There are more states out there that have very tight control over what advanced practice nurses can do, and many of them even require that they only work directly with a physician at the physician's office, or they work in a facility like in ICU as an intensivist, or where they work under a chief medical officer. So we have some very different rules and laws, which is based state by state. Okay. The second recommendation is that we expand opportunities for nurses to lead and diffuse collaborative improvement efforts. One of the biggest things on this one is the fact that providers, no matter who they are, typically do not spend more than an hour with their patient at any given time. However, nurses spend a total of 24/7 with their patients, especially in the acute care facility, or if they're doing home health visits and that sort of thing, it's generally more than an hour, giving us the opportunity to actually do a better job of educating and collaborating with respiratory and physical therapy, and ensuring that all of this is done for the best that it can be for the patient. The third barrier for this last report, or the third recommendation, is the implementation of nurse residency programs. But what you need to know is a lot of the facilities already do have those programs. They're called new grad programs. Banner, Abrazo, and I believe Honor Health is doing one, and St. Joe's doing one. But what you don't know is that GCU is the only RN BSN program in the entire United States that has implemented a nurse residency program during the student's final semester. And so you guys are actually part of cutting edge, and I think that's a great thing. And it's helping to adhere to the recommendation number 3. I would like to make sure I can't see your hands, so if you have questions or anything, please make sure that you ask questions. So Allison says, can you please lower the screen a little? It's cutting off some of the words. So I'm actually still on the very first objective. The others, I will get to those as we get there, and I will scroll down to get them. You actually have this blueprint available to you. All of the instructors posted these exam blueprints, 1 through 4, because these are what you are to study for. So, Allison, is it cutting off the first one from just Module 1, Objective 1? This one right here? Okay. I just want to make sure that I'm getting everybody's information and questions. I don't believe it's cutting off the very first one, and I will scroll down as I get to those objectives. I'm currently working on this one. So the 4th recommendation for the last article or report is that we actually need to increase the proportion of nurses that have a BSN to 80% by 2020. So they're actually requesting that we have 80% of our nurses that are taking care of patients have BSN level degrees by the year 2020. And I can tell you right now we're probably going to not make that, but we are improving that. And I do know that Arizona, the state of Arizona, has actually taken on that task. And if you know anything about some of the ADN schools at the county schools, they're actually creating dual enrollment with ASU and NAU, so that when they graduate with their associate's degree, they simultaneously graduate with their bachelor's degree. So we are trying to get this done here in Arizona. The other piece of that story is that most of the facilities in the Phoenix area have decided that they will hire BSN first. Now, that has to be taken into consideration. If they're new grads, then they want the BSN level. If it is an experienced nurse and they have the BSN, bravo. If not, and they're still experienced, they will go for that experienced associate degree, just because they already have experience. The biggest problem is the fact that we don't have very many experienced nurses out there who are still in the facilities that are not already precepting a new hire or new grad. Makes things difficult. The next piece for the very first objective is that we double the number of nurses with a doctorate degree by the year 2020. And I can tell you that the nurses in the state of Arizona that have a doctorate degree is less than 50 in the entire state of Arizona. And I can tell you that those who have their MSN, be that a master's in nurse practitioner, education, leadership, those numbers are still in the double digits. They're not in the hundreds. So if we don't have enough master's people, it's very difficult to get more people into the education programs. So the more BSN we have, the better we can move along the line and get more people who are further educated and get them into educating future people. To do that, we have to actually ensure that nurses are engaging in lifelong learning. That's the other recommendation. We do have to ensure that we are engaging in lifelong learning. So please remember that getting your RN, BSN, is just the first step. It's not the end. Because even if you do not go back and get any further degree, you still have to do lifelong learning because healthcare changes actually on a daily basis. I know that over 35 years ago, healthcare looked totally different for me than it looks for you right now. The physician drug reference, the big old PDRs, well, I can tell you it was much smaller than it is now because medications, there's like so many medications. We didn't have anywhere near that number. And now it's even bigger than your med-surg book. Okay, so thanks, Allison. I'm glad you can see. I just want to double check anybody who's looking at for questions. Okay, so the last two, number 7 and number 8. Number 7 says that we need to prepare and enable nurses to lead change to advance health. One of the biggest pieces that this is talking about is the fact that nurses are the people who work the closest with patients, spend the most time with patients, and are the ones that are looking at preventative care rather than reactive medical care. And yet we are the least amount of people who are on any kind of hospital or medical boards that are offered. So we actually need to and continue to be trying to join the boards and become an active voice so that we can completely advocate for patients the way that we actually should. The very last one is to build the infrastructure for collection and analysis of interprofessional healthcare workforce data. So what we're talking about there is the fact that, you know, nurses don't work in a silo. We actually do work with healthcare providers. We work with cardiopulmonary therapists or respiratory therapists. We work with physical therapists, occupational therapists. And we actually need to do some training together and some studies together and then collect that data and analyze how it's going. And then maybe make some decisions on how we can make things better for patients all the way around. So now I'm going to look at the second objective here. The second objective says you need to relate the IOM report evidence to the major changes in the U.S. healthcare resulting from current federal health legislation. Really and truly what that means is that you just need to be able to look at the federal legislation, which is actually our Affordable Care Act, and be able to explain how the Affordable Care Act affects nursing practice. And it's changed nursing practice significantly. Our focus in healthcare is now on prevention, which is what nursing is all about, rather than the curative or reactive response of medicine. We also need to recognize that we have many more people who have insurance that never had insurance before seeking out that preventative care. We still have quite a few people who are using the ER for their primary care, but our preference is that they actually go to a preventative provider, and that would open up the emergency room for emergencies and urgencies. Because they utilize the emergency room as their primary providers, this is where all of the long waiting lines in the emergency room have come from. So how is the Affordable Care Act going to affect how you as a nurse practice and how the environment that you practice in might be different? The third objective is that you be able to articulate the effects of your current federal health legislation on that nursing practice. So we kind of talked about that a little bit in number 2. But the biggest deal is that you be able to summarize those major recommendations of the IOM in their 2010 report, and that's the 8 that we just finished talking about. Removing scope of practice barriers, expanding RN's opportunities to lead, implementing those new residency programs, and like GCU, putting them back into the school program would even be beneficial. And that's what GCU is showing. Increasing the number of BSN RNs to 80% by 2020, doubling the number of nurses with doctorate by the year 2020, ensuring that we engage in lifelong learning, preparing and enabling nurses to actually be able to lead change in order to advance the healthcare to where we need to go. And the last one, building that infrastructure for collection and analysis of interprofessional workforce data. The fourth objective says that you are to summarize the major recommendations of the IOM from 2010, Futures Nursing, Leading Change, Advancing Healthcare Report. So the big thing here is those recommendations that those 8 recommendations that we just did, but we also have to know that this is where we actually talk about the Nurse of the Future core competencies and the associated KSAs that go with those. That'll be number 5. So 3 and 4 go together, but 5 is where we start talking about what you've been learning the entire time you've been in school here. The Nurse of the Future's core competencies, and then what are your knowledge, skills, and attitudes that you use and actually do in order to meet those particular core competencies. So please remember that on your clinical evaluation tool, you've been doing that all along. So we're looking at patient-centered care, professionalism, leadership, systems-based practice, informatics and technology, communication, and when we say communication, we mean effective communication, teamwork and collaboration, safety, quality improvement, and evidence-based practice. Okay, so does that help, I hope, clarify the differences between 3, 4, and 5? Now, the last one, number 6, is asking you to be able to identify the Institute of Medicine, the IOM priority areas for national action. Now, this came from a 2003 report. It is also in your IOM book. But those priority areas are those core competencies of IOM. And so that would be patient-centered care, interprofessional, interdisciplinary, and teams, employing evidence-based practice, applying quality initiatives, and using informatics. The other component to that is what are chronic issues that need to be addressed, such as diabetes, hypertension, obesity, poor communication when transitioning from one area of care to another, such as an acute care facility to maybe a home health clinic, or maybe even to a rehab facility. So those are some of the things that we really need to be able to focus on and make some changes in. Like I said, that is also in your IOM book. So at this point, I am going to make sure that there are no questions regarding the very first module, okay? So module 1 is all about the Institute of Medicine and the reports and how we have nursing care in the past and what our future is going to look like. So if you have any questions, please make sure that you type them in. Sarah says, can I please repeat the 8th recommendation? And yes, that 8th recommendation is to build infrastructure for collection and analysis of interprofessional healthcare workforce data. Really and truly, all that means is that we need to be able to start working together so that respiratory therapy school and RN school, and then, of course, the PA school, and maybe even a medical doctor school, we should all work together and help us figure out what's going on and how we can actually make better impacts. So I'm hoping that you understand that. Amber says, I've been meaning to ask, is enrolling in the master's program okay to do after we graduate, or do we need to get working time under our belts first? Amber, great question. What I can tell you is that it depends on your university that you're choosing to go to. I do have one student who was actually enrolled in her master's program the last 2 weeks of her bachelor's BSN program here with GCU. And she did not require any kind of time and grade on the job work. I will tell you it depends also on what kind of thing you are going to be reaching out for. Nurse practitioner, is it going to be family? Is it going to be pediatrics? Is it going to be adult? Is it going to be geriatric? So you actually have to look at the actual facility that you want to attend and what the criteria requirements are. For GCU, I will tell you that to move into the master's program, they do request that you have some on-the-job experience. I'm not sure what the requirement total is for that. You're welcome, Amber. Okay, so I don't see any other questions right now. So what I would like to do now is go to Module 2. Now remember, IOM is 10% of this test, this exam, but those questions are key questions. So if you actually review the chapters that have those IM reports in summary, you will have a better opportunity of getting those questions correct. The second module is about complex care and the cardiac facility or the cardiac system and the disorders. 55% of this exam. What I do want you to know is that we really and truly have not taught you anything you did not already have an introduction to. The only thing we really introduced was ventilator care, and we did that in respiratory. We are actually having you think about things differently than you have in the past. We're now trying to help you think more like a nurse than as a student, because very soon you will not be a student and you will have to be able to make decisions based on your clinical judgment. And so you have nursing instinct that you've been creating throughout this entire program. Now you need to learn to trust the instinct that you have created. You need to learn to trust the knowledge that you have. And that's part of what the questions do here, is to help you transition into that nursing thought process, because that's what NCLEX is all about. So remember, with the very first one here for the care, all we're doing is we're going to make sure that you understand the nursing process and management of patients with specific perfusion disorders, because perfusion disorders cause a life-threatening issue. So you already know about dysrhythmias, already know about MI, acute heart failure, both right and left, pulmonary edema, and cardiovascular disorders. You also know about the nursing process. So your ability to assess your patient, make a plan. This says you need to analyze and then make your plan, implement that plan, and then evaluate. Did the plan work? And if it didn't, what do we need to do differently? So one of the recommendations that I make to all of my students is that for every single question on the exam, I highly recommend that you go A, B, C. You need to save their life first. So do they have a patent airway? Second, are they breathing? Third, is there circulation, meaning do they have a pulse? Now, if you get past those things, then now you move into the nursing process. So very first thing is you have to assess your patient so you know what the heck's going on before you can really make any decisions. But do I want to assess my patient, listen to lung sounds, if my patient doesn't have a pulse? No, I do not. I need to save their life first, A, B, C. Then I can move into the nursing process, add PI. And that will help you prioritize your answers, okay? So number one is saying that you need to be able to provide the management of care via the nursing process, add PI, for all of these perfusion disorders. And again, they are not new. The second one is talking about you being able to explain the physiological basis for hemodynamic monitoring. So really and truly, how do we insert a PA cath? Where does it go? And what kind of readings does it give us? That's what it wants to know. So not only a PA catheter, which gives you the PA pressures, the CVP pressure, and even a wedge pressure. You also need to be able to describe an art line, an arterial line, because that gives you systemic pressure. And please remember that you need to actually calculate a map for you to be able to make a decision on patient stability, because remember, map of 65 means that even the kidney is getting perfused, and so that right now means that we're a little bit more stable. Your CVP tells you volume status, and it gives you your right end ventricular diastolic pressure. Your PA diastolic will give you your left end diastolic pressure in that ventricle. However, the pulmonary capillary wedge pressure, PCWP, we also call that a wedge, also referred to as the pulmonary occlusive artery pressure, gives you a more precise reading. So let's say I have a PA diastolic of 18, but when I actually occlude the pulmonary artery by blowing up the balloon, I actually get a reading of 20. That means my left ventricular end diastolic pressure is actually 20, but it's a dangerous thing to be inflating that intra-aortic balloon on a frequent basis. And so if you are 2 points off, then you can use the diastolic part and recognize that as the diastolic changes, so is your wedge changing. And you can look at trends and then not take the risk of inflating the balloon and the balloon rupture, throwing all of the material into the lungs. How about pulmonary artery rupture? Making lung infarct because we forgot to deflate the balloon. So all of those things are high risk for patients. Make sure that you are able to use these devices for the most accurate information regarding your patient, for the most appropriate care that you can provide. Okay? You need to be familiar with phlebic static access, square wave test, over-dampened and under-dampened. If the transducer drops below the patient, what kind of a false reading would I get? And if the patient has slid down in the bed and it's higher than the phlebistatic axis, what kind of false reading would that give you? And please remember, please, 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 you do not treat the numbers. You treat your patient. Now, if you look at your patient and your patient does not look good and it looks like what those numbers say, then yeah. But you always need to assess your patient because those numbers may or may not be correct depending on whether the patient slid up or down in the bed, whether it's leveled correctly. Always treat your patient and not the monitors, okay? If the monitor and the patient agree, then it's okay. The third one for cardiac is where we're talking about the normal versus the abnormal for stroke volume, cardiac output, and then any kind of changes that might occur. So this is where we're talking about heart transplants, we're talking about cardiomyopathy, we're talking about that might be a restrictive cardiomyopathy, it might be a dilated cardiomyopathy, and so you need to be able to understand how that works. And then what changes might happen. And one of the big things is being able to differentiate between right and left heart failure. Please know that right heart failure, if it backs up enough, it will lead to left heart failure and pulmonary edema. Left heart failure can back up enough that it actually can cause peripheral edema. Please be sure that you understand the differences with asterixis, because that's a calcium deficit, and you put the cuff on, you start to blow it up, and they start flapping on their wrist. Asteristics, make sure you remember that. The other component is that you need to be able to recognize your EKG rhythms and be able to interpret them and then choose the appropriate treatment for each of them. So, for example, a critical thinking or clinical judgment question would be, I give you the measurements of the rhythm. Now you have to decide what is the rhythm. And then I might ask you what kind of treatment modality would the nurse anticipate receiving from the provider. So if you get the interpretation correct, you're going to get the answer correct. If you get the interpretation incorrect, then you're not going to get the right answer. And that helps us understand whether you have that critical thinking flow down yet, okay? The last one is cardiac medications. I can tell you this exam, this #1 exam, is heavy on cardiac medications, very heavy. Medications for use in the ICU, I know that several medications have been mentioned by the different instructors. Please ensure that you are familiar with the cardiac medications. I'm not sure how many of you have the NCLEX review, Silvestri's Saunders, the purple one, but I will tell you behind each of the systems there is a dedicated medication chapter on that system. And I highly recommend that you do that, especially for cardiac and respiratory for this exam. The other piece is if you get onto the online piece where you can go in, I would like for you to change the cognitive level so that you are getting application and analysis questions only. Then you can pick your content level and go down at the very bottom. There's a pharmacology, and it's got like hundreds of pharmacology questions, which can help you with your HESI review, which is coming up. Please remember your pharm HESI is actually one of your exams to make your overall average. So you have 5, okay? So actually that covers the cardiac modality. So I want to look and see if there are any other questions. Asterixis, it's actually spelled with an X, and it was a calcium deficit, and you learned about it in Med-Surg. So you might want to look it up and refamiliarize yourself. It's okay if you spelled it wrong. I just want you to be able to look it up, spell it correctly. So it's AX, asterisk, okay? So you can look that up. It's actually in one of the PowerPoints as well. It tells you about that. Now, where do we find the 5 questions online? So it's if you have the Silvestri NCLEX review book, you have the ability to get in there and practice NCLEX questions, and that's where you will find that. If you need more information on that, please don't hesitate to, one person from each clinical site or each clinical cohort email me at tj.land, L-A-N-D, at gcu.edu, and I can actually talk you through it, and then you can post that in your individual LoudCloud LMS, Learning Management System, for your group. so that I'm not bombarded. Well, it's like over 1,000 emails, but I can still get everybody the information, and I will be happy to talk you through that. So by measurement of EKG, do you mean the specific? So yes, I'm talking about PR intervals. I'm talking about QRS measurements, QT measurements. Okay, I am talking about those. The other component that I want to talk about is that please be able to recognize what you would and would not defibrillate. Okay. Then it says, did you say that right-sided heart failure can cause or lead left-sided heart failure? Yes. If it gets bad enough and it's not treated, it will develop into the other kind of heart failure. It just keeps backing up because it's all one big circle. And once it gets backed up, it's going to then continue to back up. Sandra, I actually talked about the pacemaker code in the cardiac review that I did. I will tell you that you only have to know the first 3 columns of any of the pacer codes. The first one tells you which one is being paced. The second one, it means which one is being monitored. And the third tells you whether the machine will trigger or inhibit. And I really recommend that you speak to your faculty so that they can share that with you, or you can actually go to the posted website for the cardiac component piece. Okay? Sorry that I can't spend more time on that because I want to do the respiratory component. When is main campus's first exam? Albuquerque, yours is tomorrow, and our first is Monday. So we are all doing them within 7 days of each other. So yes, you're okay, which is why we're doing the component prior to you doing your exam. You needed to have this review. So let's go on and do the respiratory piece, and if I do have time, maybe I can go back and speak to the pacemaker code chart, Sandra. Let's see how that works out. So the acute respiratory component is where it's 35% of your exam, 35%, which means a total of 14 to 18 questions. The very first component is where it's saying that you need to be outlining the nursing process in the management for clients who are experiencing acute respiratory distress. Now please remember, acute respiratory distress is very different than acute respiratory distress syndrome. So acute respiratory distress could be allergic reaction and I'm having airway closure, or it could be exacerbation of asthma, could be acute exacerbation of COPD. That means they are in respiratory distress and it is acute, not chronic. Please know that that's very different. So we're talking about asthma, COPD, pulmonary embolus. One thing on COPD, please remember to recognize that both bronchitis, chronic bronchitis, and emphysema are the 2 kinds of the most common COPD cases. Now, there is only one thing that differentiates them from each other, and that is the fact that emphysema causes physiological body changes, creating the barrel chest. Please remember that. So go back and refresh yourself on PE. And then the second one is talking about the nursing management of patients using a variety of modalities which include mechanical ventilation. So be very clear on what's the difference between modes and settings. There are 2 kinds of modes. One is volume and the other is pressure. And then there are settings that are set in each of those. The only one that really is different is that in the volume mode, we actually set how much air is being poured into the lungs, and then we actually just measure the pressure that creates inside the lung. But when we go pressure, we take that pressure and we set that as the pressure limit, and then we actually measure how much tidal volume is going in, and we can tell what the lung compliance is, okay? So you need to be able to tell the difference in that. Please recognize the difference with acute respiratory failure. Know that less than 8 respiratory rate, you need to intubate. Please know that patients in the 50-50 club of their PA O2 and PCO2 of their ABGs, they need to be intubated. And they'll probably be mechanically ventilated to help correct those issues. So those are some of the things you need to remember about that. The ARDS component is that is the stiff lung. That's where we have to start doing a lot of continued pressure inside the lungs. Please be sure that you refresh your memory on the difference between CPAP and bilevel or BiPAP, because there's some questions about that. We might be able to use BiPAP to prevent from intubating somebody if they're struggling and may not have to invade their body and increase their risk of ventilator-associated pneumonia and those kinds of things. One of the big things I want you to remember is that oral care and elevating the head of the bed is extremely important in the prevention of ventilator-associated pneumonia. Ventilator pneumonia can actually turn into adult respiratory distress syndrome or acute respiratory distress syndrome. There's a difference between the respiratory distress and then the respiratory distress syndrome, and you need to be able to understand that. The last component is that you actually refresh yourself on chest tubes, because one of the things that you need to remember is that with ARDS, which is the respiratory distress syndrome, we start getting a decrease in the compliance or elasticity of the lung tissue. That actually means that we have to increase the amount of pressure to force air in and try to get gas exchange, and that actually can cause trauma, barotrauma, which is barometric trauma, too much pressure, or volutrauma, meaning we put too much volume in there and we actually busted the balloon, which is your lung. So a chest tube has to go in. And remember the difference between a pneumo and a hemo, and then of course a tension pneumo, right? So you have a lot of things to pull from your history. I actually do not have anything else that I want to go over, but I do have some questions. I thought COPD was barrel chest, not emphysema. Here's what you need to understand. COPD is an overarching title, and underneath that title is emphysema and chronic bronchitis. Those two both are types of COPDs, and it's emphysema that gets the barrel chest, not the chronic bronchitis. So you have to go another level, okay? Sorry about that, Callie. I hope that helps. The difference between CPAP and which one? Okay, CPAP is the continuous positive airway pressure. That's similar to what people use when they're at home and they want to prevent snoring, right? All that does is that adds a continuous positive airway pressure. In other words, it is a continuous pressurized flow that goes into the oral and nasal pharynx, and it actually creates enough pressure that keeps the tongue from falling back into the back of the throat, blocking the airway, causing the snoring. BiPAP allows us to do CPAP, but it also allows us to do PEEP. And that means CPAP, we add continuous positive airway pressure at the beginning of inhalation. With PEEP, we are adding positive end expiratory pressure so that they have enough pressure inside their lungs to help push them open and help dilate and open up the alveoli. Because in ARDS, those alveoli have collapsed with any kind of lung insult, especially pneumonia, or we have to consider aspiration, aspiratory pneumonia. And if it's a gastric aspiration, not only do they aspirate fluid where gas exchange should be, we also have to worry about the fact that it's an acid, and the hydrochloric acid burns the trachea, the bronchial trees, and gets into the actual alveoli sacs. So burns are kind of important. Rebecca, I'm hoping that that has actually helped you a little bit. I just wanted to make sure that I answered all the questions. Sandra, oh good, Rebecca. Sandra, I'm going to take a few moments and try to help you understand the pacemaker piece a little bit. The way I usually draw this out for my students on the board, because I'm very visual, and it helps me talk my way through it as well. Please remember that when we are putting in a temporary pacemaker or even a permanent pacemaker, we can put that lead, which is the electronic receptive piece, or the wire component, in either the atrium or the ventricle, and both of them are on the right side. So in the very first column, which of those chambers is being paced? Where is the lead that will actually shock the tissue? And that would be either atrium or ventricular. So let's say somebody had a really massive MI that took out all of their SA node. And how we would know that is the SA node isn't working, and we start getting junctional rhythms, and it backs up and gets the atrium with retrograde POA. That's a lot of things that you don't have to know. What I do want you to know is that if the heart rate is too low and they drop their blood pressure, they are now symptomatic. They can insert a temporary pacemaker, put the electric lead into the atrium, and they can actually pace the entire heart from that atrium. Now, if the lead is in the atrium and there's not a sensing lead in addition into the ventricle, then whatever's in the first column is typically going to be in the second column, because that's the one that we are monitoring, okay? The first one is what lead is getting the juice. The second one is telling us, okay, so which one are we monitoring to give the juice? Because we used to have a lot of other different kinds. And then the very last column is either T, where we actually trigger an impulse to the tissue, or I, we inhibit an impulse to the tissue. So trigger would be like the SA node is gone and we completely take over, so we would just put it to a trigger mode. So that would be an AAT. The atrium is paced, I'm sensing the atrium, it's not working, so I am doing a guaranteed trigger at a rate of whatever is set. Okay, does that help? I hope. Now, when you get Ds, those are dual. That means both atrium and ventricle for the pacing, atrial and ventricular for the sensing, monitoring, and then I also can do both trigger and inhibit. So if the patient's heart rate is set for 70 and they beat at 68, it'll trigger a pacing impulse. But if they beat more than 70, say at 74, then it will not send. It will inhibit that impulse. It will not send that impulse. So I'm hoping that that helps you understand a little bit better. Olga says, is there a way to have an access to previous webinars? Yes. Where you have subscribed to get to these live components, there's a YouTube link for you to go on YouTube and be able to listen to them again. So the very first one that we did was test-taking strategies. The second we did was on the cardiac component. And then last week I did a respiratory component. And then this week we're doing a complete content review for the actual exam based on your blueprint. So I'm hoping that helps you, Olga. Is there any other questions that you guys have? You're welcome, Olga. Sometimes it's hard to understand when you have so much information coming to you at the same time. So we are actually like 5 minutes over. I want to say thank you very much for attending this content review for Exam 1 for 421. Again, I am Professor Land. I am one of the course chairs, and I am the main campus faculty. So please let me know if there's anything that I can do, or please let your faculty know. We are all here for your success, okay? Awesome, Leah. Thank you, Priscilla. Thank you, Vi. Very welcome, Jennifer. I'm going to sign off now. Good night, everyone.